So today I will talk about my work on improving telemedicine for neurosurgery. This is actually a project that I've become very passionate about over the past year. It started as a quality improvement project that has now turned into a business venture. The need for telemedicine has become obvious at this point, but the two main reasons for it are the following. First, number one, hospital systems have been rapidly expanding. They've grown their catchment area, which means that patients travel far to meet the right surgeon for them. As a result, for that reason, all these patients have to have a number of preoperative and postoperative visits to make, which is particularly challenging when you're recovering from a big surgery. And second, as we all know, the COVID-19 pandemic really changed the landscape of healthcare. And it helps us realize that as neurosurgeons, we see patients in a number of settings every single day. We round on patients in the ICU, we see consults in the ED, we see patients in the clinic, and then suddenly we have to go to the OR. So we realize that the need to decrease our exposure risk is paramount for both for us and our patients. So the first part of my quality improvement study was a retrospective analysis of patients that were seen in clinic or via telemedicine at our department from February of this year through April 18th. And we compared those to historical controls from the previous year. Our goal was to determine the use of telemedicine before and after the shelter-in-place measures, and also determine if there was a trend across the 4 divisions. Our patient population included patients that were seen by the 15 attending neurosurgery faculty, 2 neuro-oncologists, and the 2 nurse practitioners. Now, we're all familiar with FaceTiming and Skyping, but as you can imagine, carrying out an efficient telemedicine clinic is a lot more complicated than just that. It often involves a laptop or a desktop, a tablet, and a smartphone, all of which devices are used to run telemedicine apps, softwares like Video or Teladoc, which is what Jefferson has integrated into Epic, or other HIPAA-compliant software like Zoom or Doximity. So it's the combination of all these devices and the software that allows for a smooth and effective telemedicine clinic. As you can imagine, it gets complicated and time-consuming when you have to talk to the patient, examine them, you have to share your screen and review the imaging with them, you have to take notes on every patient encounter, and you also have to have your nurse talk to the patient and schedule follow-up appointments, imaging, and even schedule surgery. So all of that takes time. And learning how to do it efficiently, it requires a good balance between all these devices and software. Early on, as the entire enterprise switched over to using telemedicine, as you can imagine, there were a lot of technical issues that were encountered. For that reason, a lot of the faculty used other HIPAA-compliant apps like Doximity and Zoom, like we talked about earlier, using your own phone, your own smartphone, to avoid the network congestion that the Jefferson network encounters. Not only that, in addition, planning your telemedicine visits at times where that do not coincide with the rest of the providers is also very helpful to avoid bandwidth issues. Here's a graph of our experience. So the vertical dotted line here represents the March 13th lockdown measure implementation. And you can see here, this dotted line shows the average number of visits via telemedicine before COVID, which was on average 4.4 per week. And after COVID, you can see here that the number of visits rose dramatically up to an average of 180 visits per week, which is a 40-fold increase. Now, that's still not as high as the number of visits of patients, in-person visits in clinic prior to March 13th, which was on average 640 visits. But that's in the context that the COVID-19 scare made patients only seek care if there was an urgent need. The use of telemedicine increased across all divisions significantly. Most prominent was in tumor and spine, where the number of weekly visits will average 70 and 77 visits per week, but it was a significant increase across all divisions. And lastly, historically, telemedicine has been used only for post-op visits, but through this experience, we noticed that there was a significant increase in the number of new patient visits, which is represented here by the patients with, that were not known to the practice, sought out and met a new surgeon for the first time via telemedicine after the lockdown measures were implemented. The range of new patient visits ranged from 13 to 32% across the 4 divisions. Now, through this whole experience, we learned that the telemedicine software that we're utilizing are still very limited in the ability in providing the physician with an ability to perform a comprehensive physical exam. There's still a lot of things that a neurosurgeon cannot test using telemedicine alone. So for that reason, Dr. Evans and I worked on developing a novel software that allows for physicians to examine patients from the comfort of their own home. So patients can undergo cranial nerve and neurophthalmic testing remotely in an automated fashion without the need of an assistant in person. So our goal is we're planning a pilot trial that's going to start in September of 2020, this year, in order to compare our software with the gold standard testing in 200 patients with brain tumors. Once we prove our technology, we're going to expand to stroke, epilepsy, multiple sclerosis, and other neurophthalmic disorders as we're collaborating with some faculty from Lausanne. And this technology not only can be useful in the outpatient setting, but it actually has a tremendous potential in the inpatient setting, where there's a number of patients that could be, that we can get neuro checks very frequently and in a reliable, objective fashion without them having to be in the ICU. They can be anywhere on the floor and still get Q1 neuro checks, for example, if needed. So I'd like to thank Dr. Evans for his help throughout this process with the product development and conception, and then Dr. Harrow, Dr. Sharon, and Dr. Boer with the quality improvement portion.